So Dr. Potok is currently funded by an NIH Career Development K-23 grant. She's recently been appointed as Assistant Professor of Clinical Medicine at the University of California, San Diego. She pursued her medical education in Paris, France, and completed a primary care residency in May of 2012. As a CSN Fellow, she had research aimed to assess muscle mass frailty in older adults by using the difference in estimated glomerular filtration rate by cystatin C versus by serum creatinine. She was and is our Clinical Scientist and Nephrology Fellow 2019 to 2021. Dr. Potok, take it away.
Hi, everyone. Thank you for giving me the opportunity to present my research here, and thank you to AKF for funding this research for the past couple of years. My research project was to look at the clinical information beyond kidney function that is embedded in the difference in glomerular filtration rate by cystatin C versus creatinine. So a little bit of background, you probably all already know this, but the way we assess kidney function is by calculating this GFR, and we usually use serum creatinine to do so. So the kidney function is basically the ratio of the creatinine production to the serum level. And this creatinine is a product of muscle metabolism, and so its concentration in the serum is influenced by many factors, including muscle mass and age, gender, ethnicity, and various factors. Next slide, please. And so there's another marker of kidney function, cystatin C, which has been in play for the past 10 years or so, but that is only recently has only recently been more used clinically. And it's been shown to be a better predictor of end-stage kidney disease and death from all causes and cardiovascular events. And the cystatin C is secreted by all the nucleated cells in the body, and not only by muscle. And so it is not influenced by muscle as much as creatinine is. Next slide, please. This is from this paper from Glasslock from 2017, just showing that there are other factors that do influence cystatin C. It's also not a perfect marker for kidney function. Chronic inflammation, obesity, thyroid dysfunction, being on steroids can influence cystatin C. So it's also not a perfect marker. Next slide, please. And so my project started by seeing patients in clinic who had different GFRs when calculated by cystatin versus creatinine, and you're left with two markers and you don't know which one to trust. Next slide, please. And so basically, these are the two extremes of the spectrum. On the one hand, we have frail, older patients that are referred to us that have a pretty low serum creatinine, and it's actually probably because they have low muscle mass and their GFR by creatinine looks great. But if you check a cystatin C, the kidney function is maybe not that great. And on the other end of the spectrum, we often see in clinic some bodybuilders who are referred to us who have a high serum creatinine, probably because they have high muscle mass and their GFR is a little bit low, which is why they're referred to us. But if you check a cystatin C, their GFR is actually okay. And so we started wondering if maybe if we looked at this difference, it could tell something about functional status and frailty. And we looked at this difference constructed as higher is better. So we looked at eGFRDiff being eGFR cystatin minus eGFR creatinine. And so if this difference is negative, you're towards the frail old lady that I just show you a cartoon of. And if this difference is positive, you're rather on the other end of the spectrum with a bodybuilder. Next slide, please. So during my T32 research fellowship, I looked at this in two cohorts, the cardiovascular health study and the SPRINT study. Next slide, please. So the cardiovascular health study is a cohort of elderly participants aged 65 and higher. And then the SPRINT study is, Dr. Wong actually talked to you about it, and I'm sure you all know about it, is a blood pressure study of participants aged 50 and older. And so we showed in these two cohorts that this eGFRDiff is not only associated with frailty, but also with cardiovascular events and mortality. And so if this difference is negative, you're at higher risk for bad outcomes. Next slide, please. And so we came to think maybe muscle explains this relationship, since muscle influences creatinine more than cystatin C. Next slide, please. So my AKF project was on the health, aging, and body composition study, which is a cohort of elderly, older adults aged 70 to 79 who are pretty functional at baseline, independent for activities of daily livings, and without any issues for walking or climbing stairs. And we limited our samples to those with measures of creatinine and cystatin C at baseline, as well as imaging on CAT scan and DEXA scan. And so our predictor was this eGFRDiff, which is eGFR cystatin minus eGFR creatinine using the CKD-EPI equations. And our outcomes was functional status more so than frailty, using the Health ABC physical performance battery, which was created for this cohort specifically, which looks at 4 different tasks: a usual walk, a narrow walk on 20 centimeters apart, chair stand, where you have to stand up without the help of the hands, and then standing balance. And there's a score from 0 to 1 for each of these tasks, looking at the performance of the participant divided by the best possible performance for that task. So you end up with a score between 0 and 1 for each of these. And so the total comes up to 4 as the maximum score. And so the higher score means better performance. Next slide, please. And so this is to show you our results. So we divided the population by eGFRDiff, using plus and minus 10 as cutoffs. We had used plus and minus 15 in our previous work because 15 is clinically relevant. It makes you go from one CKD stage to the next. Now we use 10 here as the cutoff so that our groups would have decent sizes. And so I put in the cartoons here to help orient ourselves. And so this shows you that this difference goes from minus 47 to plus 77 in this cohort. And actually, there's a significant number of people who have more than 10 points difference between the two GFRs. And then, so looking at this, participants in the negative eGFRDiff group tended to be have more comorbidities, such as hypertension, diabetes. The age is about the same throughout for the whole cohort. The age is 70 to 79 years old, so it's a narrow range. And then looking at those frailty measures, so we looked at the Health ABC physical performance battery score. And you see here that as you go towards the right-hand side of the table, the score gets better, so better performance for those in the positive group. We looked at poor functional status that we define as the lowest quartile of this score, but we actually found similar results when looking at the lowest 10% or lowest 30% of this score. And so there are a higher proportion of people in the negative group that are in the lowest quartile, more fallers and weaker grip strength and slower gait in the negative group as well. Next slide, please. And then looking at the measures of muscle and fats and body composition on the CAT scan and the DEXA scan, you can see here that basically those in the positive group tended to have bigger muscle, higher muscle area, larger muscle area on the CAT scan. Those in the negative group tended to have a larger fat area on the CAT scan, and the DEXA scan was not really significant differences between the groups. And so we chose to look a little bit more at the total thigh muscle area because it was the measure that had the strongest association with eGFRDiff and with functional status. And we thought that if we were to show that accounting for muscle would make the association between eGFRDiff and functional status go away, we could show it with this total thigh muscle area. Next slide, please. And so we started by looking at the association between eGFRDiff and thigh muscle area here. The top line is looking at this eGFRDiff continuously, and then on the in the bottom looking at it by groups. And you can see here, so model 1 is just adjusted for demographics, and then model 2 is also adjusted for inflammations and cardiovascular risk factors and kidney function. And basically being in the negative group made that those in the negative group had a thigh muscle area that was about 14 square centimeters smaller than those in the reference group. And those in the positive group tended to have larger thigh muscle area. Next slide, please. And then we looked at the association between eGFRDiff and poor functional status. And we model 1 is adjusted for those same criteria as same covariates as the slide before, so demographics and cardiovascular risk factors. And then we adjusted for several measures of body composition individually and taken together. And you see here that the signal remains the same. The association is a little bit attenuated, but it doesn't go away. And so being in the negative group was associated with higher odds of poor functional status, no matter which measure of muscle or fat or body composition we took into account. Next slide, please. Thank you. And this is looking at the same thing, but looking at eGFRDiff continuously rather than by groups. And so again, the signal is the same per standard deviation increment in the eGFRDiff. The odds of having poor functional status was lower, and this remained true even after adjusting for all those measures of body composition. Next slide, please. So the take-home points that I take out of this study is that, first of all, it confirmed the previous work we had done that eGFRDiff is clinically relevant and associated with poor functional status, and that lower eGFRDiff is associated with lower muscle quantity and muscle strength. But despite this association of eGFRDiff with low muscle area and low muscle area, the low muscle mass did not make the relationship between eGFRDiff and functional status go away. Next slide, please. So my conclusions of this is that it is clinically relevant to look at those two markers rather than average them. And having a negative eGFRDiff is associated with poor outcomes. And I think especially in older adults, checking a cystatin C to confirm creatinine GFR and see if they're in agreement or not is very important. Next slide, please. I also wanted to mention during my AKF Fellowship, I also worked on the Berlin Initiative study. Next slide, please. The Berlin Initiative study is a cohort of older Germans. They're age 70 and older. Next slide, please. And we looked again at this eGFRDiff, and the Berlin Initiative study has measured GFR in their cohort. So they measured GFR using iohexol, which is kind of the gold standard to assess kidney function. And we were wondering if perhaps we could use eGFRDiff to determine, which of the GFRs we should actually trust to dose medications and to actually know what the true kidney function is. And so again, we divided this cohort in eGFRDiff groups, and you can see here in blue the average eGFR cystatin, in green the average eGFR creatinine, and then the red line is the average measured GFR. And looking at this box plot, you can see that those in the negative group have the eGFR cystatin that seems to be closer to the measured GFR, but those in the positive group actually have the creatinine GFR being closer to the measured GFR. And I find this really fascinating in trying to determine what we should do with these information in clinical practice. Next slide, please. And so now the aims for my K23 will be in two different cohorts, the Hunt study and the in regards. So I had worked during my T32 research fellowship with Dr. Stein-Hallen on the Hunt study, which is a cohort in Norway looking at people living in the north of Norway. All residents were included. And Dr. Hallen had looked at the kidney failure risk equation, and that was created by Tengri in 2011, and the mortality risk equation that Dr. Bensal came up with in 2015, and looking at both in the same population to kind of assess the competing risk of death in end-stage kidney disease in people with chronic kidney disease. And so now that I have shown that this eGFRDiff is related to bad outcomes, my first aim in my K23 award is going to look at this Hunt cohort and see if adding the eGFRDiff to those equations, the kidney failure risk and the mortality risk equation, would improve the ability to discriminate this competing risk of death in end-stage kidney disease. And then my second aim will be to do the same thing in the regards cohort, which is an American cohort, as you may know. And then in my third aim, I am interested to see if we could use this eGFRDiff to decide on medication dosing. And so I will recruit hospitalized patients at the VA in San Diego who are getting IV vancomycin because we can actually measure vancomycin level. And some people hospitalized at the VA are in the spinal cord injury unit, where patients often have lower muscle mass. So I think it will be interesting to see if we can use eGFRDiff to better predict if cystatin GFR versus creatinine GFR can help better dose vancomycin and check a vancomycin trough to decide that. Next slide, please. And I also wanted to mention I've been involved in this C3 initiative from working with people at UCSF and at Durham, Virginia, trying to implement more awareness about cystatin C and to have it more checked more frequently in people in the hospital and in outpatient settings. Next slide, please. Yeah, these are my references. And I wanted to really thank the American Kidney Fund because it was an honor to be one of the fellows and a great opportunity for me. It gave me time to, publish my work and get to now I'm working with mentors in Norway and in Germany, and it's just been an amazing experience. And it allowed me to apply for a K23 also, which I'm really excited about. I wanted to thank my primary mentor, Dina Rifkin, who's been really amazing in supporting me since day one, and Joix, who is my division chief and my co-mentor. These are also the co-authors on my Health ABC study, which we just submitted and revised and resubmitted, so hopefully will be published soon. And I wanted to thank the research group at San Diego, who's been really helpful.